Saskia I've been in conversation with Saskia over the last few months, and she works in palliative care and in Dorset, and is looking at the ways in which Dorset, it's the university trust, isn't it? Medical trust, Saskia, but you've been talking specifically with the palliative care group locally and nationally. So over to you to explain what you've been thinking and what you've been doing. Just so that everybody knows, palliative care is working with people who are dying, and it's about making sure they are able to die well, in essence. Saskia.
Thanks ever so much, Amanda, and it's so brilliant to be here. Thanks for inviting me, and just really enjoying the conversation so far. And I think a lot of those themes will continue into this. So yes, I think there's loads we can do in palliative care. And I was struck actually when I was doing a search in preparation partly for this talk, and if you put into your Ecosia search engine palliative care and climate change, there's much more about the palliative care that the planet needs than there is about what's happening in palliative care as far as climate change, which is kind of salutary. I want to believe that there's still something we can do about it, and the planet doesn't quite need palliative care just yet. But anyway, so as Amanda said, I'm Saskia Dorman. I'm based at Forest Home Hospice here, which is part of University Hospitals Dorset NHS Foundation Trust, very catchily. And I also work a couple of days a week in the Southwest regional team as clinical lead for end of life, just over the last 18 months or so. So that's opened up some different kind of conversations with regional and national colleagues, which has been fab, and Amanda's very much helped us with some of those. The view here on that first slide, so that's where my mum is buried. She died a couple of years ago, and I wanted to sort of dedicate this to her, really. That's the beautiful spot in which she had a natural burial. I'm not going to be able to go down to the next slide now. There we go. So this is where I'm based. This is the office where I'm sat, is in this building here, and these are some of the lovely team. So we've got a community team, so that's Hazel on the left. I won't go through all their names, but there's community team, there's the hospital team as part of Poole Hospital. There's the ward, kind of the unit where we have 12 beds, 9 at the moment with COVID, counselling, lymphedema services, and all sorts. So it's an NHS hospice, but it's well supported by the Forest Home Hospice charity as well. As I said, we're part of University Hospitals Dorset, so that's just to flag up that there are 3 hospitals that recently merged just over a year ago, and there's obviously the Green Plan as part of UHD, which Tracy Lyons will be talking a bit more about later on this afternoon. So I won't go into too much detail on that, but just to acknowledge that we're part of a very big combined acute trust. And Amanda's already talked a bit about what palliative care is and does and what we're all about, and to me this is part of what we do. So improving the last years of life, being able to recognise when the end of life is approaching, being able to help people to be comfortable, symptoms controlled, etc. Being able to understand and anticipate what might happen in the time they have left and what's reasonable to expect about that. So that importance of communication, understanding what matters to people, really listening. I think supporting people to live well as part of their communities is an important element, although in medical training and education and clinical practice, that element of living well, as I'm sure many of you on the call will that will resonate, that doctors and nurses probably don't always think about supporting people to live well, if we're always thinking about prescribing stuff. But to me, that's a really important part of it. Being able to support people through illness in a way that feels right to them, and being able to support people who are close to them. So I think that if we do all of those things well, reliably, then we can not only improve the last years of life, but we can also improve planetary health as well, for the reasons that Kath and others have talked about. If it's good for humans, if it's good for communities, it's good for the planet as well. So this isn't an either or. This is about doing this really well and doing all we can to improve planetary health as well. So I think by understanding what really matters and focusing on that, we can not only enable people to have a better experience, but also that often leads to fewer tests, investigations, treatments, and so on. We see that all the time. I'm sure people on the call are seeing that too. If we can enable people to feel really well supported at home, then they're less likely to need hospital. And Kath's already talked about that. As soon as you kind of get into that secondary care sort of tipping point, a whole load of activity just seems to happen, because that's the way the system works. So the more we can do to support people well at home, the better. And I also think there's something in palliative care around how can we help to enable that kind of cultural shift in how we think about and how we feel about death and dying. That I don't know if any of you have read The Worm at the Core, shown on the slide there, but I think it's a brilliant book, and it talks about evidence from lots of different contexts where people, if you get people to think about death and dying, they tend to kind of consume more, or they tend to give out harsher judgments if they're a judge. They tend, it can have so much unconscious impact on how we feel and what we do in other respects that we'd never even dream about. So I think, all the kind of let's get a new car, let's build a shiny new hospital, let's buy stuff. Some of that is to do with not being able to bear the fact that we're only on this planet for a limited amount of time. So I think that palliative care, not just palliative care professionals, but in terms of how people who are involved in palliative and end-of-life care, that by enabling kind of conversations and helping people to feel less terrified of dying, that can actually help to have an impact on consumerism as well. So I think there's some really interesting parallels there with fears of death and dying and fear of climate change, and we're too scared to talk about it. I think we can do a lot to bring those together. This is just from the net zero plan from last year from the NHS as a whole. Just the bit I wanted to highlight really was the where they've broken it down into ambulance, community, mental health, acute, primary care, and non-clinical stuff along the top. Just looking at that kind of is a reminder of how much the acute setting is a very big driver of a lot of the carbon emission impacts of the health service. We know that NHS is responsible for 4% of our country's carbon emissions, and most of that is by the acute settings, and also primary care medicines as well, which Kath has talked about already. So I think A, that's scary, but B, it gives us a real opportunity here. If we can impact what happens in health, we can have make a massive difference here. And that's just a bit of a breakdown of different areas that impact on carbon emissions. I think it's interesting though, kind of look at it like that kind of hides some of the way that we make a difference in that. And so you probably, in a sense, you can't see palliative care in that slide, but it's kind of hidden all the way around. This is some work from the Nuffield Trust from a few years ago, so this is talking about financial costs at the end of life. So the last 90 days of life, we know that financial costs just increase dramatically, particularly in those last few weeks. They didn't include a kind of a carbon emission breakdown as well, but we often see, don't we, that financial costs mimic climate costs as well. It's a lot of activity that's creating that. And what's really interesting in that paper, in that report, was that they showed that if we on this next slide, so if we get support in the community right, that's the red line down here. If we get support in the community right, we can absolutely kind of flatten that massive increase in activity. And so that kind of sharp increase is all to do with people being rushed into hospital, perhaps when they didn't even want to be, all the tests, investigations, and the stuff that happens when you're in hospital, and particularly when you're really sick and near the end of your life. But if we can recognise that people are approaching the end of their life and understand what matters with them and enable that support to be in place, we can absolutely kind of cut off that dramatic increase in activity, as well as enabling a better experience for people and their families and so on. So it feels again like a win-win to me. This was an example, so it's a slightly different example, but thinking about personalised care more generally, so not specifically around palliative care, but I think it touches on some of what we've alluded to earlier in the conversation. So this is an example from North Devon, looking at personalised pathology services. So 5.5 million tests a year for their population, and over half of the biochemical tests were for ongoing monitoring of chronic disease in primary care. Again, linking back to the kind of fatty liver, diabetes, the kind of metabolic syndrome and things that we talked about. So an awful lot of testing is to monitor diseases and chronic diseases in primary care. And some of that is based on evidence-based guidelines, but that's not always the case. So in North Devon, it was an amazing piece of quality improvement work, actually, and they kind of really rigorously looked at why people were having the tests, and they found that lots of full blood count testing was being done routinely without a clear reason, and similarly for liver function tests as well. And that wasn't only having an impact. So again, unnecessary testing has a climate impact, but also it's having a knock-on impact. So anxiety over a slightly low blood count, which didn't really lead to anything, apart from if you've got a slightly low blood count, then you might go on to have an endoscopy. So, a tube to have a look down and a tube to look up and to see what the cause of the slight drop in blood count is. So one abnormal blood test result has a follow-on effect of other investigations that lead on from that. And that, as well as the kind of impact on people's mental health and so on. So it's really over investigating people, and by doing this quality improvement work, they managed to massively reduce, you can see in the top slide, the top corner there, massively reduced the amount of testing they were doing, which had financial benefit as well as better impact for environment as well. And they also, in wound care, they were finding that lots of people were having wound swabs, which weren't adding anything to the person's care management. And so by looking at that, at what happened, and improving the use of venous pressure testing and so on, rather than relying on wound swabs all the time, they found that people's ulcers got better more quickly, and they reduced the number of wound swabs they were taking by 3/4. So I think there's massive amount of stuff we can do that would reduce investigations and improve patient care as well as the all the stuff you talked about, Kath, in terms of the asthma inhalers and so on, which I hadn't quite appreciated just how huge that impact is. But I think there's so much we can do. So if we can move from a kind of business as usual, investigate, diagnose, treat, much more to those better conversations which we talked about, understanding what matters to people, a strengths-based conversation, social prescribing, link workers, absolutely kind of to be involved in that, then we can just make such a difference. Again, this is a wider example than palliative care. This is about a story of a lady who was going to be rehoused. She was going to the local authority to be rehoused, and it's just sort of showing what a bespoke by default kind of response, the difference that can make as well. So this is a lady in her late 80s. She'd lived in the same place for decades. It was her home, but her garden, that wasn't her garden, but her garden looked a bit like that. It was a bit of a mess because she wasn't really able to manage it anymore. And she was, having difficulties with the neighbours weren't very happy, and she'd been asked to move out, and so she was saying, "I need a new home." But the team involved in this particular situation, instead of just saying, "Okay, we'll put you on the list for a new home then," and all that entails, they had a conversation with her and tried to understand what was happening. And she explained that she hadn't been able to look after the garden. The neighbours had a young daughter who really wanted to play in the garden but couldn't because it looked like that. So instead of just saying, "Let's put you on the list for a new house or new housing," the team went round, cleared the garden, had some conversations first and checked in with the neighbours, and they said, if it's cleared, we'd be more than happy to look after the garden. That would be absolutely lovely. So the team cleared the garden, the neighbours looked after it, the little girl had somewhere to play, and the lady in her 80s was able to stay in her home that she lived in, and everyone was getting on better. So again, this isn't palliative care particularly, although it could be end of life care, but simple solutions that we don't think of in our kind of normal protocols and pathways that have just become business as usual. I think there's so much scope for this if we can be a bit more creative. So then I wanted to talk a bit about, so I'm near the end of the slides, but I just wanted to talk a bit about what we're doing at the hospice, or what we've just started to do at the hospice, because I think there is, as well as the stuff that we can make a difference within healthcare, I think that there is very much a case of let's get our own house in order as well. And I think we're just on the beginning of this journey. It's really inspiring to hear about some of the stuff that's happening in Cornwall and elsewhere, about people who are very much further on the journey. I think we're just at the beginning of this. We have started to talk about it, and I think that's a good initial step. So whether it's in initial just informal conversations, whether it's at our team meetings, as Manda was saying, we kind of talked about it in some of the regional meetings and the national meetings, at trying to get it on the agenda, because if it's too easy just to ignore otherwise. So we've been talking about it a lot. We're using much more kind of phone calls and online meetings rather than necessarily face-to-face, like lots of people encouraging walking, cycling, using better forms of transport. There's still quite a way to go, I think, in terms of reducing printing and single-use plastic, but a couple of our healthcare assistants on the ward are really kind of eco-champions and are absolutely coming up with some brilliant ideas and kind of ways to reduce single-use plastic. So that's fabulous. And then we've got other ideas about, we've already got lots of LED lighting, for instance, but there's more we could do with the building, for sure. Healthier food we've talked about already, and again, I think I've been veggie for like 40 odd years, and I've always been a bit kind of nervous about talking about it. I don't want to raise it, don't want to I've been, for whatever reason, kind of reluctant to talk about it. But I think with this, and knowing that diet is a massive part of how we can address the climate emergency, it feels like, well, it's not just kind of get over myself, and actually we do need to talk about it, and with colleagues as well as with patients and everyone really, and just making it something that is something we talk about, and it's just not an undiscussable. I only found out the weekend about Ecosia, but now it's kind of on all my devices, and that's what I'm using. So every 45 searches a tree, and it's such a simple thing to do, isn't it? But to make a difference. This hadn't quite appreciated the difference in terms of climate impact with if you recycle compared to if you're disposing of clinical waste in this sort of way. But just knowing that enables us to be much more proactive about saying it's really, really, really important that we get stuff in the right bin. It sounds really obvious, doesn't it? But I think there's masses to be done there. That's just a kind of, I think business as usual is the left-hand column, and I very much kind of want to do whatever I can to help shift the culture to the right-hand responsible practice. Because I think when we talk about accountability and all the kind of business as usual kind of targets, policies, protocols, etc., it can tend to make people feel quite defensive and fearful and justify, and we're doing this, but just trying to look good. Whereas if we move to responsible practice, this is all of our responsibility, this is what we have to do, something that we can do this together. It just enables us to be much more creative and proactive in what we're doing. There's similar things really, we need to move away from tick box assessments to kind of understanding people's story, people in context, move from what's wrong to what matters and what's strong, and so on. I think that that's similar to some of the stuff we've been talking about already. I started with my mum, and I wanted to finish with my son, and this is a piece of picture he did a few years back. I want the earth to be greener, cleaner and safe for all animals, and I'm thinking he and future generations definitely the reason why we're doing this, isn't it? Just so important. So I'll stop sharing there.
That's brilliant. Thank you so much, Saskia. And I'm going to go to Will, but just before I do, I think it's really important. A lot of this is about communication engagement, and it can be really hard when you're suggesting any sort of change at all. So please see us as a wider family, and we're all learning from each other on this strange and challenging journey. And I'm sure there's lots that we can all share. So we just need to stay together on this. Will, you've got something to say?
So of these changes, which we all want to happen, one huge barrier in the NHS is just the enormous pressure that everyone's under, and the busyness, and the eye rolling that you get because everyone is changed out, aren't they? You know. What is the new way that we can get over that? Oh my God, someone wants to change something. A, I'm bored of change. B, I just haven't got time. How do we reframe this? I mean, I know we use the benefits, but how do you sort of get in there? Because everyone is knackered in a whole new way, aren't they? Including myself, and we're changed out. So what's the what do you think?
It's a really, really good question for anybody to answer, because there's one set of challenges trying to engage with somebody who doesn't want to do change at all and is very against it. And then there's another challenge if you've been asked, like in the NHS, where there's a regime change of some description every couple of minutes, and it's just exhausting. Have you got any thoughts on that, Saskia, in terms of how you're engaging people locally?
I think kind of having the informal conversations is good, and not saying, not starting off with, we need to do this, this and this, but kind of inviting people's ideas, I think is good. I was on a call earlier with one of the board level, and we were talking about something quite different, but I felt enabled and empowered or whatever by this group, and to say, well, that's got a climate impact too, hasn't it? Because if we do this, that's good. And he was like, oh, that's a really good call. And it was something that it was quite interesting, because it wasn't about setting up a different meeting to talk about it and to kind of say, we need to do this, this and this, but it was just kind of trying to weave it into what we were already talking about. I don't know if that's any help at all. I absolutely get the kind of, it's all so horrendously busy. We're just trying to survive, keep our heads above water here. No time to think about anything else. But I think we have to keep going, because it's going to get worse, isn't it?
Yeah, it is going to get worse. You're absolutely right. And I think integrating it, I spoke to a councillor over the weekend, and he has managed to get climate change onto the agenda for every single council meeting, which is just an incredible revolution in terms of every single thing they discuss is framed by this. So you're not actually asking them to change everything, you're just saying, but now we need to see it through this window. So I absolutely hear that. I've got, I think Ryan and Kavita both want to say something, possibly somebody else, but I can't see their hand. So I'm not very sure who put your hand up first. I'll let you decide.
I'll go then.
Go.
I was just going to say, I think because we're at a point of desperation now, that this is the time to change. And so last week we had a partners meeting, and it was full of doom and gloom, and we've got significantly less number of doctors than we should have, and everyone's feeling it. We've had lots of sort of high staff turnover over the last 18 months. And then sort of 3 days later, we had brought the social prescribing team in to talk to us, and it was complete opposite. It was a message of hope and actually of all proactivity and all the things that they're doing. And so I think now is the time for us to really be turning things around, because we can't carry on as we are, all feeling the pressure, or having to well, I'm having to work more, but it's sort of actually now is the time to do it. And I think people are more on board with these conversations. And certainly I know from conversations in our practice, whereas sort of a year and a half ago I felt like I was on at people and trying to make changes, whereas now everyone's on board really, and they're all trying to do what they can. So yeah, I think we've got to believe that anyway, otherwise where do we go?
Yeah, and I think when we start to talk about it, people are almost relieved sometimes to talk about it, because they've been feeling it too, but just feeling like they're alone. So I think that's a really helpful thing.
Yeah, I would completely agree with that. Actually, I'm going to go to Ryan now, and then quickly from Gemma, and then we're going to go over to you, Alan, because I know you've got a school run. So Ryan and Gemma.
Well, it's just reflecting really back about what Bill was talking about how do we do it, and actually my points really have been made by you guys as well, but I would just echo that thing primarily from what Quaid is saying, which is about framing it in a hopeful way. A lot of times I talk to people now, they're just all very negative about a lot of things, and there's me being negative, so I'm not going to do that. So there was a really great little piece. Cass already mentioned Artie, who's really big in the Greener Practice Network, and I'll just paste a little link in the chat. And I thought it was really nice what she did in the RCGP. They have a little email they sent out every week about just saying, and it's a little piece usually by the president, and she got it for 1 week, which was lovely to get because that goes out to all GPs. And she didn't frame it like it's a disaster, world's burning, it's all terrible, we all need to make massive changes, sort it out, you idiots, just get your act together. What? She instead said, this is my vision, doesn't it look lovely? And it was. I read it and I went, I would love to work in an NHS like that. That sounds amazing, you know. And so framing it in that way, I think, can be much more positive than lots of other people. When they come in, they'll say, we need to sort it, this is a problem, and people are just full of lots of problems. They just go, I can't deal with another problem. But the other thing is about the persistence, just it becomes the norm. So getting things onto the agenda, so it just happens repeatedly, and then it becomes normal. I think someone was saying to me not too long ago that, you know, health and safety when you're coming to build a building or something is now normal. You obviously would think about that. There's no question. Why isn't it normal to have the likes of sustainability on every agenda? And it will be. It just, the question is, will we do it quick enough? But be hopeful and be a hopeful message, I think. So I'll just post that in the chat.
Absolutely. Yeah, that's brilliant. Thanks very much. Completely agree. I've just put From What Is to What If by Rob Hopkins. Definitely worth a read. We might as well have something amazing to head for. There's lots and lots of different socio-psychological reasons for that. Gemma, I'm going to go to you, and then we're going to hand straight over to Alan, who's going to give us a rapid canter through fabulous carbon management on some of the estate that he's been working on. So Gemma, what was your query?
It was along the lines that I couldn't agree with Ryan anymore. Absolutely, wholeheartedly support those comments. It's about how we frame these things. So it's about talking to different general practices. Everyone's too tired, like you said, there's exhaustion, but it's how we sell it. We say this is a long-term solution. Look at how we can reduce demand and how we can improve appointment availability, and about expanding our workforce so it doesn't always keep coming back to our AMPs, our GPs, our nursing team. There's actually people that are out there in the community that can do it. So it's about a workforce that actually is sustainable as well. You know, there's actually possible to increase this workforce as well. That's been quite well received. Just on another one on how we frame it to patients, I think it will actually also increase access to people, because quite a lot of people that I've talked to that haven't been coming to the surgery have said, I don't want to come to the surgery because all you're going to do is give me a pill. You're going to give me a sticking plaster. I want to get better. Whereas if now we come out and say we can provide holistic care, we don't want to give you medication. We don't want to do that. We want to help you. And if we can provide that whole sort of nurturing care for them and actually create it within the community, I think we'll actually increase patient access and build trust between patient and GPs, which I think is essential right now. So that was just my last point on that.
Absolutely, I couldn't agree more with all of that. It's about trust and social capital and understanding that the team is all of us, really, without sounding too cheesy. It is absolutely, there's a whole different way, lots of different ways of delivering, more than one way to skin a cat. When it comes to health, we've got to get really, really canny with our cats, I think. Absolutely.